this Sunday morning. Today, we are going to discuss a very important investigative modality, or even I can say an indispensable VR diagnostic tool, that is OCT angiography. OCT angiography, it is a non-invasive tool and has now been there for a decade. The non-invasiveness of this tool makes it a very desirable tool for any VR surgeon. So we are going to start today with a brief introduction about the utility of OCT angiography and how can this be used in research. For this, I would like to invite Dr. Devesh Kamawat, an assistant professor at RP Center AIMS, a young and dynamic surgeon, a avid researcher, and a very kind person. Dr. Devesh.
Thank you, Dr. Ankur, for the kind introduction. Good morning to all. So I'll be taking you forward with the basics of OCT angiography. So OCT angiography is a dialysis angiography that we all know, and it constitutes of en-face imaging at different levels in the retina choroid, can be even the optic nerve head. And since there is segmentation of individual layer which is possible, there is no overlap of the vascular structures, and we can visualize the vascular structures in individual slab. Now, since no dye is used here, there are no dye related side effects, as well as there is no leakage, no pooling, so there is no obscuration of the vascular architecture that happens with leakage and pooling, and so we can clearly visualize the vascular architecture in OCT angiography. Now, what is the principle of OCT angiography? Basically, it relies on the decorrelation signals. Now, what are decorrelation signals is that there is a difference in the reflected light from any interface when successive images are taken at a very brief interscan period. So repeatedly you are having multiple scans taken at the same place, and any difference in the signal which is there between the two images, now it is taken that would be because of the motion. Now, since retina is an immobile structure, we presume that motion happens because of the blood flow. So OCT angiography, it detects the blood flow, it does not detect the the vasculature. So basically it detects the blood flow in the vasculature and not the vasculature itself. Now, there are different methods that are used to detect this motion contrast. One principle is the amplitude decorrelation. Amplitude decorrelation means that you're detecting the difference in the amplitude of the reflected light between the successive scans. And the second principle is the phase variance, in which other than the amplitude, you detect the difference in the emitted light wave properties rather than the amplitude. You are focusing on the phase of the light which is reflected back. Now, there are other methods to improve the signal quality in OCT angiography, and accordingly you name the algorithms according to that, such as split spectrum OCT angiography, that is the amplitude decorrelation angiography. Then you have the speckle variance and volume averaging. Now, I have no financial interest, but there are multiple platforms that are available commercially, and they have their own trade-offs. Now, the important thing to remember here is that these platforms will segment differently. So, majority of them will segment the VR interface anywhere from the ILM to 200 to 300 microns. Then you have the superficial slab, which is between the ILM and the inner plexiform layer. Then you have the deeper layer, deeper vascular plexus, that is layer which is in between the IPL and the outer plexiform layer. Then you have the outer avascular zone, which is basically from the OPL to the retinal pigment epithelium. Then you have the sub-RP and the choriocapillaries and choroid. So there is some difference between the individual platforms. Each one have their own advantages and disadvantages. So some of them are spectral domain OCT based, whereas others are swept source. So on the left side, you can see it's the Spectralis by Heidelberg. Again, no financial interests. And on the right side, you can see it's a Angioplex OCT angiography by Cirrus, Carl Zeiss. And this one is the swept source OCT angiography, that is the DRI OCT by Triton. And the important difference between the swept source and spectral domain here is again the better penetration that we achieve with swept source OCT angiography, and otherwise the principle remains the same in both of these. Now, it is important what scan size we should choose while we are going ahead with the OCT angiography of the tissues. Now you can have different scan size available in different machines. Traditionally we have 3 into 3 mm or 4.5 or 6. Now longer or larger scan size are also available in the few of the machines, such as long as 12, and now we have the ultra wide field also coming up, which can provide even view till the mid periphery. Now important here to differentiate between the scans is that the resolution will depend on the scan size. So even though we can achieve a larger scan that will provide us a better larger area to evaluate, but on the left side you see it's a 3 mm scan, and on the right side it's a 6 mm scan. In the left side we can see the microaneurysms, but in the right side we cannot see the microaneurysm that clearly. So the resolution does decrease in a larger scan, and also there is a problem of artifacts coming in because you are detecting a motion, and bulk motions because of the eye movements can occur if the scan acquisition time is prolonged. Now coming to the interpretation, whenever you are interpreting an OCT angiography image, you have to do a concurrent assessment of multiple things that you have to take care of. First, you have to make sure that the area of interest is captured and the scan is properly centered. Then you come to the en-face OCT images in different slabs. Before jumping to any conclusion on these images, you need to check the corresponding B scans, whether the proper segmentation is done or not, whether if you're looking at the superficial plexus, whether it is segmented from the ILM to the IPL or not in the OCT B scan. And then you also check the flow overlay, because sometimes the abnormality may be very minute, the membrane, an abnormal membrane may be there which may be very small, but you may still be able to pick any flow on the OCT overlay, and that will be depicted by the hot color red. Then at last you also have to look at the structural en-face OCT image, intensity image, because your signal may be impeded because of any media opacity which is there. Maybe it is the hemorrhage, maybe it is drusen's. So the signal intensity may be reduced and you may misinterpret it as a flow void or a flow deficit, and otherwise it would be just a decrease in the signal intensity, which is because of impeded transmission. Now different artifacts can occur in OCT angiography because it's a very sensitive tool. It will be affected easily by any movement of the eye, or there are other side effects, other artifacts as well. So coming to the motion artifact, it occurs because there is some movement which is there. Although there is eye tracker present in all majority of the machines, the threshold may be outside the threshold of the machine, and small movements may still not be compensated. So these motion artifacts will appear as white streaks across the image, and to how the machine takes care of it is that it may rescan the affected area if that option is there, or you can have softwares which correct this motion artifact using horizontal and vertical raster scans. So using the horizontal and vertical raster scans, you can know what is the displacement of the image, and then you can align the image using the software and get a motion artifact free image. Now next is the projection artifact, which is basically an erroneous appearance of the superficial vascular network onto the deeper networks, onto the deeper levels. So in this image you can see the superficial plexus, which is visualized here, the large vessels which are visualized, but when you see the angiography slab at the level of choriocapillaries, still you are able to see these large vessels which are erroneously appearing in the deeper slab. Now why does it happen is because at any deeper level, whatever light intensity is coming, already it has been affected by the flow which is above it. So if you are looking at the choriocapillaries level, already the light which is coming to the level of the choriocapillaries, it has been affected by the flow which is there in the superficial plexus, and therefore these projection artifacts commonly occur. Now there are different ways these projection artifacts could be removed. Initially we had the slab subtraction, in which we used to subtract the superficial slabs from the deeper slabs, but that leads to loss of the signal intensity, and therefore the machines now they are coming up with newer proprietary softwares aiming at projection artifact removal. So if we see here, this is the spectralis by Heidelberg, and there is the superficial plexus which is visible here. On seeing the deeper plexus also, you can see there is a projection artifact which is there, and in this, if we apply the projection artifact removal option, then the superficial vessels are removed. So in this we can see there is an option to choose the projection artifact removal option, and this can be chosen if you want to remove this, and as a default it is always chosen. And just to highlight that projection artifacts can occur, I have unselected it and shown you the images here. Now segmentation artifact occur because the machine, it automatically segments based on the predetermined retinal boundaries which we have gathered from the healthy eyes. So any alteration which is there in the retinal anatomy, it will make the machine mislabel the boundaries. So if we see this example here, the yellow arrow can make the area in the which is denoted by the yellow arrow, you can misinterpret it as a flow void or a deficit of the vasculature here. But if you see the corresponding OCT image, you see that the segmentation lines are above the retina in this area, so there is no vasculature in this area. That's why this absence of vasculature is there, and it's not an actual flow void. And similarly, if you see the blue arrow, some vessel complex is seen in the deeper angiography plexus, but however you know that it's a sub RP membrane which is there, and because the segmentation lines are here passing through the sub RP level also, and rather this should have passed above. So the machine is not able to do that, and that's why these segmentation artifacts occur. But you can manually change the segmentation. You can bring it above this hump in this area, and then have a true picture of the angiography deep plexus in that area. Now last is the shadow artifacts. If you see this image, you can misinterpret it as having flow voids in the center, but when you see the intensity intensity image and the OCT image, you know that there is lot of edema which is happening, and this signal transmission is impeded because of loss of because of lot of edema, and it's not just because of flow deficit. So anything like edema, a gross edema or drusens or blood can have this shadow artifact. In this example, we can see there are a lot of drusens which are there, drusenoid PEDs, and erroneously we can see that the shadow is casted here in the choriocapillary slab, and you may misinterpret it as a loss of choriocapillaries in this patient. Now there are different ways you can, different matrices that are available with us. Since we are very beautifully able to capture the vasculature, we can even quantify it. So the traditionally we have the vascular density and the perfusion density and the phase metrics which are available with us. So on the left side, if you see, it's the vessel density metrics that are shown. Vessel density is basically length of the perfused vasculature. So you consider all the vessels to have a caliber of 1 pixel. You ignore the thickness of the vessels. You consider them as a caliber of 1 pixel, and then you check how much is the length of the vasculature in the per unit area given. And on the other hand, if you see the perfusion density is basically the area of the perfused vasculature, that is, the thickness is also included here, and then you calculate the perfusion density. The phase, you can have an automated phase metric such as the phase area, the circularity index, and the perimeter or the circumference, and you can manually also calculate it. If the machine is not able to do it, you can trace the phase and calculate these manually. Manual or semi-automatic threshold segmentation can be used, also be done using ImageJ softwares, and there are different thresholding algorithms which binarize the images into perfused and non-perfused, and according to the pixels, white pixels and the total pixels, you can calculate the perfusion density. Now important here is that you should use the same algorithms which are used if you want to compare the data on follow-up, and you should not compare in between the different platforms which are available, because always different thresholding algorithms will give different results. Now other factors, other matrices that are available are the fractal dimension, vessel diameter index, lacunarity index, and the flow void densities. These are being looked up into in the upcoming research studies, and there are other image processing systems also available other than ImageJ that can be used, such as Fizzy, AngioTool, Octave. Coming to the limitation, that is my last slide. So you have certain limitations of OCT angiography, that is the field of view may be limited, although we are coming up with wider ultra wide field scans also, but they are affected by motion artifacts and other artifacts. You have the segmentation and the projection artifacts that may impede the quality of your scans. Then the vascular structures with low flow, such as microneedles and polyps, may not be imaged well, and they may be missed, and you may not be able to differentiate between leaky as well as non-leaky abnormal vessels, and cannot comment on the transit time in OCT angiography. Thank you.
Thank you, Dr. Devesh. So I would like to thank you that you have summarized the all basic of OCT angiography in very crisply. Just one question that I think I wanted to ask you. You have been, being in RP center, you have availability of swept source OCT angio as well as, other OCT angio spectral domain. So for a beginner retina specialist, what do you think should be the ideal way? Should he invest more to buy a swept source OCT angio, or is it good to start with just the spectral domain OCT angio?
So I've shown you the images. Even the Cirrus, that is the Angioplex by Carl Zeiss, it also provides beautiful images. I have used it at AIMS Rishikesh and LHMC also, and I was able to use it in my clinical day-to-day decision making. So that is also good enough. And the Spectralis by Heidelberg, sometimes I feel that provides a better slab information rather than the swapped source imaging.
Thank you. So,
Can I? Yeah. So just for the benefit of everyone, so you beautifully highlighted how OCTA is done, what are the side effects, or you can say artifacts, and then what are the limitations. What are the clinical cases where you feel now you don't need to do FFA at all, but you do only OCTA and it's done?
So where you don't have a clinical, first is when you want to confirm. When you want to intervene and you want to confirm, you need not go for an FFA. Just document it using an OCT angiography.
In which variety of cases? I mean, diabetic retinopathy. Which disease?
So CNVM, if they are clinically, you can visualize the CNVM. You need not go ahead with an fluorescein angiography. Just document it with OCT angiography. And sometimes when you have small membranes which are there, they may be picked up on the OCT angiography, and you need not do a fluorescein angiography in those patients. And also on follow-up, when you want to see the change in the network which is there.
So one category of cases you want to say is when you have macular neovascularization or neovascularization due to any
Second
cause.
would be the CNP areas. We can pick up the macular ischemia also on OCT angiography. Need not go with fluorescein angiography in maybe old BRVOs when we have suspicion of BRVO, that it could be an old BRVO, vision is unexplained. So we can go ahead with OCT angiography and look for macular ischemia on that.
Okay. Thank you.
So as we all know, India is an endemic zone of diabetes mellitus, and sooner we are going to be the capital of diabetes mellitus of this world. So diabetic retinopathy is a very important topic, not only for ophthalmologists as well as postgraduates. So to give us the insight of such an important topic, I would like to invite Dr. Vinod Kumar, professor at RP Center AIMS. He's a brilliant surgeon, a loved teacher, and an avid researcher. He currently holds the post of professor at the very prestigious RP Center, New Delhi, and is a quite sought after international speaker. To you, sir.
Thank you, Ankur, for kind words. And at the outside, I would like to thank you for making me a part of this. We know that people are always gaga about OCTA, and so what I am going to tell you is what has been our work on OCTA in patients with diabetic retinopathy, and what is the current literature as to what it suggests, what we can do with OCTA in current scenario. And third is what I feel is my judgment in today's scenario, what all we can do OCTA in patients with diabetic retinopathy. So when it comes to diabetic retinopathy, we know that color fundus photography has always been the standard. OCT has revolutionized the way we look at diabetic retinopathy for past 2 to 3 decades. I think it's indispensable now. And fluorescein angiography always has been the gold standard for almost all the retinal diseases. We were limited by the view traditionally, but since the advent of ultra wide field imaging, I think the fluorescein angiography images what we get in patients with diabetic retinopathy is awesome. What we get is it takes 2 to 3 minutes, but what it gives is indispensable. And I still continue to keep on doing ultra wide field angiographies in these patients. So I'll come to our work first. We compared we did this study around I think 3 years back, where we wanted to compare how does FA fare to OCTA in patients with the diabetic retinopathy, and we wanted to assess if there are any vascular changes which we could detect on OCTA but were not seen on angiography. So of course this was a thesis given to one of our candidates. It was a cross-sectional study. We included eyes with patients with diabetes who had diabetic retinopathy and no diabetic retinopathy, and patients with diabetic retinopathy were further divided into non-proliferative and proliferative. So we collected all these patients. All these patients underwent fundus photographs, OCTA, and wherever we could do FFA, we did, but we did not do FAs in patients with where there was no clinical diabetic retinopathy. So we compared, we did 3x3 as well as 6x6 and 8x8 scans, and initially we tried to assess whether we could see the various lesions which we traditionally see on that is microaneurysms, the size of FAZs, the CNPs, capillary non-perfusion, both in the mid-periphery as well as the posterior ones, and then the other lesions we assessed as well. So I'll directly come to the changes. Now microaneurysms we know is the first feature of diabetic retinopathy, and we found that in OCTA we could beautifully see the microaneurysms. And it is a traditional teaching that when in diabetic retinopathy you see a number of microaneurysms, you go on to do FFA and you will see many more. Okay, that is traditional. But the opposite happens in OCTA. When we do OCTA, what we see microaneurysms is much less as compared to what we see on FFA. Now that is little kind of contradictory, but I'll come to why that happens. So this is a patient, you can see there's a non-proliferative diabetic retinopathy. When we go on to compare OCTA versus FFA, you can see there are many more microaneurysms which are visible on fluorescein angiography but much less visible on OCTA. This is another patient, similar thing happening. You can see certain microaneurysms which we can see on FFA are not visible on OCTA only. So why this happens is we don't know, but probably microaneurysms are low flow lesions, and that's why OCTA is not able to make out the phase difference. Now one thing has to remember that even the color photographs, they underassess the number of microaneurysms as compared to FFA. What was different in our study, we found that even in eyes where there was no clinical diabetic retinopathy, some of the microaneurysms could be picked up on OCTA. So this is one such example. You can see clinically it looks neat and clean, there's no diabetic retinopathy, but once you go on to do OCTA, and this will happen only once you do a high resolution, that is 3x3 image, you will not see them on 6x6 or 8x8 slabs. So you go on to 3x3 and you will see some of these microaneurysms are visible even in eyes without diabetic retinopathy. Another such patient, so that is keeps on happening that, but again because there was no clinical diabetic retinopathy, we did not do FFA to confirm if they were actual microaneurysms or not, because FFA remains the gold standard for the diagnosis of microaneurysms. Now coming to FAZ, I think a lot of work has gone into FAZ. When we talk about OCTA, people have studied lots about FAZ, how to quantify the circularity. So all these things can be done differently in the superficial slab as well as the deep vascular plexus. Now that is very different from FFA. In FFA you do not you cannot dissect between superficial and deep capillary plexus, so it's a combined kind of image. But in FAZ, when we see on OCTA, we can see superficial slab and deep slab. So initially people studied both superficial as well as deep, but just to tell you in a nutshell, in today's scenario, if you have to assess FAZ, you assess FAZ on the deeper vascular plexus and not the superficial vascular plexus. That correlates better with what is going to happen subsequently to the diabetic retinopathy. So we determined FAZ size and shape in deep capillary plexus, as I mentioned, and we also found it, and subsequently other people have also shown that FAZ tends to be larger in eyes even when there is no clinical diabetic retinopathy. So that is again a useful tip we get from OCTA, that shows that there are certain vascular changes which are happening in eyes even when there is no clinical diabetic retinopathy. And when again, as Devesh mentioned, we compared the vascular density and perfusion density, and again it's a logical as well as a well established fact that as this severity of diabetic retinopathy increases, both vascular density as well as perfusion density, they go on to decrease, in a way notifying that the disease is progressing and ischemia is progressing. Posterior capillary perfusion, somehow we never pay attention in traditional FFAs because our field is very limited in OCTA. So we pay a lot of our attention in eyes with diabetic retinopathy when we look on OCTA. So these are certain eyes when we look at, you can see the posterior capillary non-perfusion areas which can be very well picked up on eyes with in OCTA. Now what happens is that because in FA we are not able to see and quantify, we really don't pay so much attention when we talk about FFA, but when these posterior capillary non-perfusions are quantified, we can see that the larger is the posterior capillary non-perfusion, higher are the chances of diabetic retinopathy progression. So again, in our eyes, in our study, we found that in NPDR, we had lesser number of eyes with posterior CNPs, and as we go on to PDR, we had higher number of eyes with posterior CNPs. Now leakage is something which gives a huge advantage in patients with diabetic retinopathy. We can see which microorganisms are leaking. We can see sometimes which small neovascularization, which is very difficult to make out, can be easily picked up on FFA. But because leakage is absent, and especially in the larger slabs, it's very difficult to find neovascularization. So that is one thing we lack in OCTA. Peripheral CNPs again can be detected provided you have a wide field OCTA, but that is again, I think in today's scenario at least, we do not have good machines which can provide a single click a larger field OCTA. Neovascularization, if large, can be very well picked up, but again you do not get the kind of contrast you get in FFA, especially with the currently available machines. So this is montage of few such patients. You can see there is a neovascularization. You can see the CNPs here, but sometimes, especially if there are small neovascularization like a small tuft and you are not experienced, you can easily miss those. And this is the other eye of the patient. Again, you can see there are peripheral CNPs and you can see a neovascularization there. One advantage is with OCTA is that you can segment at the level of ILM and you can see these NVs are actually raised and projecting into the vitreous. That is one advantage of OCTA. Tells you which NVs are raised and which are flat on the retinal surface. So by our study, we found that basically microorganisms were much lesser in number on OCTA. They are seen even in eyes without clinically visible diabetic retinopathy. FAZ is a good marker of progression of diabetic retinopathy, and neovascularization, especially not too peripherally, can be easily picked with OCTA. That is something what came out from our study, and I think most of the current literature does suggest almost the same thing. But in my opinion, especially in today's scenario, if you give me a choice, I would still like to go ahead and do ultra wide field FFA. If I just have a normal FFA, conventional FA, I probably go ahead with OCTA and not do conventional FA. But the amount of knowledge what ultra wide field FA provides is not currently not provided by the currently available OCTA machines. So another advantage of FA is that it is a dynamic process. It tells you about leakage from the phases which are there in FFA. It does tell us something about what is happening to the flow inside the retina. Because of the wide field nature of FA, we can see the peripheral CNP and NVs as well. OCTA is a very useful tool. I think this is the future. Once we start getting a full field kind of OCTA in a single click, that is the time when FA usage will decrease. As Devesh mentioned, I think in patients with macular lesions, we are already doing less and less of FFA, because OCTA gives you a wealth of information in the posterior pole disorders, but when it comes to periphery, we are still limited by the field. So it is a very useful tool. Even in patients with no clinical diabetic retinopathy, sometimes it can tell us what is going on in the retina. Early vascular changes are seen in patients with no clinical evident diabetic retinopathy, and as we go on to the higher grades of diabetic retinopathy, these changes do worsen, and it's a very useful tool for assessing the macular CNPs as well as the macular ischemia. Thank you.
Thank you, sirs, for giving us such a comprehensive review of OCTA on diabetic retinopathy. I have just
If you
please, sir.
if you allow, sir, one question that I like to ask you based on your study only, and we all have observed that when we do OCT angiography in diabetic retinopathy in the central 3 mm area, you see these beautifully capillary non-perfused areas in the posterior pole. Do you offer any treatment based on this? Do you laser those areas?
Okay, that's a very good question. Now, I repeated several times that we do see some changes even in normal looking eyes. So even if there are milder grades of diabetic retinopathy, we know that at least in today's scenario, we do not have any treatment. So even if you detect certain changes on OCTA, I think we do not have any treatment and we do not do anything. But it does show some insight as to what is happening in the pathogenesis of diabetic retinopathy. We always knew that diabetic retinopathy is a you can say vascular disease, but now we have evidence which shows that a neurological component is going on simultaneously. So I think with the OCTA-like tools, we can show that even the vascular changes happen before the clinical evidence changes. So what is going to happen is in future probably we are going to look at a treatment which is going to retard these changes and possibly nip the diabetic retinopathy in the bed before it comes up clinically. But as of now, it does not change your management at all.
Second question, sir, regarding the field of OCT angiography, you said that you prefer to do ultra wide field FFA. Now with Dream OCT being launched, it is giving us a 130-degree OCT angiography in a non-invasive way. Do you think it will do anything to change your practice, because now you have a 130-degree field OCT angiography?
I still think I will go ahead with FFA at this moment. The reason being, I think we know that with ultra wide field, what one change happened is we know that there are two kinds of diabetic retinopathy. The one kind of diabetic retinopathy which predominantly involves the posterior pole, while the other kind which involves the peripheral retina. We call it predominantly peripheral lesions, and it has been shown conclusively that patients who have more peripheral lesions, they tend to progress more. So I think 130 degrees is still kind of mid periphery and we are not able to see the periphery. And one of the newer diabetic retinopathy protocols, they have shown that the FFA lesions which you see on periphery are actually more predictor of progression than the clinical lesions which you see in the periphery. So that is again very useful thing which have come from ultra wide field FFA. And I think once we have 200 degrees, then probably it would be good enough. And one thing I forgot to mention, it's very important, OCTA is very important, especially in eyes with diabetic nephropathy, because some of these patients who have high creatininuria, these patients cannot undergo FFA, and OCTA is extremely useful in such patients. I think there are inbuilt protocols. You can mark the area manually. You can see the superficial plexus. Then you can mark the area, deep capillary plexus, and you can mark the area and calculate it manually. I think the newer machines have inbuilt protocols also, where they automatically detect the FZ and they will give you the size of the FZ.
So DRI OCT, when it came, say initially manually you had to mark the FZ, Now Spectralis, the latest software update, it gives a auto segmentation. So does Angioplex, probably Intelite. I have not seen their software updation.
Yeah, I think again, FAZ macular ischemia as such was given a lot of attention in pre-VEGF era. When we were doing laser, we used to talk a lot about macular ischemia. But with the onset of anti-VEGFs, I think we are not so much worried about the macular ischemia. And now I think we know that macular ischemia is a overhyped thing. It does not correlate with visual acuity so much, jitna ki we used to believe. Only if it is too large. Only if it is too large. Only if it is too large. Sometime if it is kind of medium term, I think medium term loss, then it's not so much correlating with vision.
I think other than the phase area, just I showed that it's the circularity index that has come up. So if the phase is, even if it is not circular, it is distorted in one part, it will signify as localized ischemia which is there. So rather than focusing just on the phase area, you may be interpreting erroneously sometimes.
Yeah, that is one problem with Octa. I think the repeatability is little dicey as of now. The measurements are different for different machines. What you see, actually, we don't know whether it is true, because lot of software developments, what they do is they try to in trying to make the image look beautiful, they put in a lot, feed in lot of data so that the fill-in gaps are filled, you know. So that's why a lot of these images will actually not show what is actually there.
So for the for the audience, I would like to share that diabetic retinopathy, when you are looking at, when you understand the basic pathophysiology of diabetic retinopathy, is the vessels that get obliterated. So when you do an foveal scan in these patients, you look at the decrease in the vessel density, means the number of vessels in that particular area. It tells you that the OCT, the diabetic retinopathy is progressing. The phase size increases, the vessel density goes down, and this tells us that there is a progression of diabetic retinopathy. This is how OCT angio is useful in diabetic retinopathy. Apart from that, has been mentioned by sir and other experts. So now I go to the another very important topic, which is about IPCV. IPCV has been always in the domain of ICG, and there's a new terminology which has come in recent year, is non leaky MNVs, which have been there, which have been evidently shown on OCTA. Before that, we didn't know much about these identities. So now for this, I invite Dr. Bhuvan, who is a very sought after vitreoretinal surgeon in private practice. He is currently working as a chief vitreoretinal surgeon in Bharti Eye Hospital, New Delhi, and he is a very avid speaker and is very much invited into various international conferences. So, Dr. Bhuvan, sir.
Yeah, so thank you, Ankur, for the introduction. Very good morning to all the chairpersons and audience. So I'd like to thank AIOS, I'd like to thank Ankur, and a very nice opportunity to meet my old friends. So I think we are discussing Octa. I think Octa is the future, but definitely we have discussed the limitations and also the advantages. I'll be discussing the role of Octa in PCV and non-exudative MNVs. Although I think Octa, before starting my presentation, I'll say that for PCV, Octa has huge limitations, but probably as newer models comes and the progression comes, probably we'll have more information. So I will not go into the details. I think PCV is a group of disorders now, is a part of a group of disorders known as pachychoroid, and which involves diffuse thickening of the choroid or of the choroidal vessels, or a focal thickening with dilated middle and outer choroidal vessels, and severe atrophy of the overlying choriocapillaries. So ICG was the gold standard for detecting polypoidal lesions, and they are seen as hyperfluorescent fluorescent hotspots, and they gradually the hyperfluorescence increases. Sometimes there is a hyperfluorescent area present around the nodules. So even OCT has a high sensitivity, but the specificity is low in detecting polypoidal lesions. These are typical pictures: a tall peak PD, a double peak PD, a large PD, a thumb-shaped PDs. So all these things, they are associated with polypoidal in about 75 to 80% of the cases, but even there is a possibility that even if OCT is showing such pictures, a polyp may not be present, but there is a sensitivity is there of around 80%. So now just showing you, this is a polypoidal lesion in a study which was published. So this is the ICG picture which is showing a hyperfluorescent spot, and when we do a B scan OCT, we can see that there is presence of a polyp at the height of the PED, and there is an adjacent double layer sign showing the splitting of the RP and the Brooks membrane with a choroidal neovascular membrane. Now this same picture we compared in the study, they compared with the OCTA images. So the OCTA images which is done at the outer retinal slab, you can see this marker. So you can see that there is this in the at the D slide, there is this white half circle which is corresponding to the area of the polyp which is seen in the ICG. Now when we go to the deeper levels in the F slide in the choriocapillaries, we can see that there is presence of this branched vascular pattern which is corresponding to the choroidal neovascular membrane in the ICG picture adjacent to the polyp. So now when we go to the G slide and we do a color composite, then we can see the circle on the left side would be marked as a polyp which is seen as a half circle. I'll just tell you why it is not so well demarcated and why it is a half circle. And adjacent to that we can see that there is presence of the choroidal neovascular membrane. When we correspond this to the B scan in the H picture, then we can see that the polyp in the color composite is shown in the height, near the height of the PD, and the adjacent choroidal neovascular membrane can be seen. So as can be seen in this slide, the polyps are not very well defined in OCTA, and this is a limitation because the OCTA is based on the blood flow, and the blood flow in a polyp is usually very less. In larger polyps, the blood flow is usually higher at the periphery, and that is why you can see the presence of a ring sign or a half ring. So it will basically pick the outer edges of the polyp. So this is another showing the different patterns of the polyps which can be seen on a OCTA. So again, as I said, this is the A2 is the ICG picture in which you can see a well-defined hotspot. There is a nodule, but when we do a OCTA, we can't see a well-defined polyp, but however, a circle lesion can be seen. So this is because the blood flow is higher in the outer part of the polyp. It results in the formation of a white circle. So another picture in which a cluster of polyps are seen on ICG. If we do a OCTA, then we can just, this encircled red spot, we can see various small white hotspots which correspond to a polyp. So you can see most of these studies have been retrospective. So if we do a OCTA and try to pick up a polyp, sometimes it's very difficult. Maybe if we already know there is a polyp, by doing end-phase images, we are able to pick up the polyp, but ICG based on all this I think is still the gold standard for diagnosing a polypoidal lesion. So these are the other patterns which can be seen on ICG. If you can see in this C2 picture, there is a very clear clusters of polyp which can be seen. However, again, if you do a OCTA, then there will be presence of these polypoidal lesions as small white lesions or half circles which can be seen because of the limited blood flow. So the last picture is again shown a small polyp, but however, since the blood flows in small polyps are very less, we can't see any well-defined pattern which can be seen on the OCTA images. So as I said, the slow velocity of the blood flow which is present in the polyps, it can't be captured on the OCTA machine, and the flow velocity which is present at the periphery of the larger polypoidal lesions is much more faster. So usually we get a half ring or a full ring formation, and sometimes the polyps are so small that they can't be picked up on an OCTA machine. So this is just one patient. You can see in this clinical picture, there is a large PVD, there is a white membrane. So this is the OCTA images. There was a large PVD on the OCT images, suspected polypoidal PCV case. But when we did a OCTA, we could see a vascular membrane, AVN pattern could be seen. However, no well-defined polyps could be seen. So based on the picture, there is presence of a half white circle, which could be a possible polypoidal lesion, but I was not very sure. So I went with the ICG, and when you do a ICG, then you can see that there is a clear defined hotspot nodule which is present at the edge of the PED, and there is an adjacent branched vascular pattern is also present there. So I just wanted to highlight that ICG is still the gold standard if you really want to see a polypoidal lesion. Also, if ICG is not there, we have a OCT and OCTA, which gives us a very high sensitivity and specificity, and we can, and based on our clinical findings, we can make a diagnosis of PCV and treat the patient accordingly. So now I'll come to the second part, that is the non-exudative MNV. I think in the first presentation only, Vinod asked a question, and the major role of OCTA was highlighted, that is to see occult CNVNs or MVNs and the FAZ. I think this is the mainstay for today, even for a basic OCTA, which is there, and it can't replace the other invasive procedures for that. So non-exudative MNV is one thing which can be seen by a OCTA, or it can be seen as a hotspot on the ICG. The definition, by definition, there is no presence of any activity, there is no macular fluid. It is an asymptomatic condition. The fellow eyes of patients, in 6 to 27% of the cases, they may have a exudative AMD. Incidence of exudation ranges from 20 to 40%, hence OCTA is a very important tool for following up such patients. So as long as there is no exudation, the studies which have been done, they said there is no need to treat it, because most of these membranes are mature and will not lead to any active lesions in future. So as compared to angiography, fluorescent or ICG, I think OCTA is a much more faster, non-invasive technique which can easily pick up these membranes, and then they can also easily be observed, and hence OCTA is the prime indication for the diagnosing as well as the observing such lesions. So again, with OCT, we can see these lesions, which can be seen as the splitting of between the Brooks and the RP layers, but it is not as sensitive and specific as a OCTA, in which we can see the proper vascular network. So this was a study which was done by Wang in 2022. In this, they were observing the MVN lesions over a period of time. So this is one of the lesions which showed that around 12 to 13 months, the membrane not only lead to exudation, subretinal fluid and intraretinal fluid, but also the size is also increasing with time. So OCTA becomes a very important tool in monitoring such patients. And then they treated it subsequently, and then based on that, only an OCTA was done for the follow-up, and the whole management was planned by OCTA. Similarly, this is another lesion in which they said over a period of time, there was no activity, there was no reason to treat it. The lesion size increased over time, however, there was no exudation. Hence, it's very important to keep on monitoring these lesions and also educate the patient that if he has any distortion in the vision, then probably he should come for management. So just my final few slides. OCTA studies have shown that large MNE complexes, they do not disappear with any treatment. Hence, there is no need to give anti-VEGF agents. Sometimes these membranes are also protective. They prevent the development and the progression of geographical atrophy. Hence, further no need for treatment, and most of these membranes are already matured also. The goal of future treatment will not be to eliminate these membranes, but to promote their maturation and prevent the exudation. So not anti-VEGF, but maybe some other form of treatment may come in futures. So as I said, they also prevent and they also slow the development of geographical atrophy. They have a preventive role, similar to these persistent subretinal fluid. So just the final slide. I think multimodal imaging, they have really helped the understanding the pathophysiology of PCV. And OCTA is a very important non-invasive tool for detecting the blood flows in the PCV. However, it has got a very limited role. It will only detect the blood flow in the large PCVs at the periphery, and you will not have a well-defined polypoidal pattern, but you may have a ring or a half ring or a cluster of white dots depending on the blood flow which is present, and can easily miss small polyps. So ICG still remains the gold standard for the detecting PCV. But you can avoid it in your private clinical practice at least. Maybe in an institute you can do it in every case. So, and for MVNs, I think OCTA has really helped us improve the detection of occult CNVNs, non-exudative MNV without any invasive, and a very fast procedure. And these membranes have to be observed over time, and there is no need to treat them if there is no activity. So thank you all for listening. And this is it.
Any questions from the audience?
So first of all, PDT was PDT, sorry, that's what I said. PDT was not available, so that is why we were not doing it. I'm not saying that you do ICG. ICG really helps to make you a diagnosis that this is a PCV. So a PCV management is slightly different from AMD. You know, in PCV you have to be slightly more aggressive. You have to even tell it may be associated with more risk of subretinal hemorrhages. So you have to also educate the patient. So that is an important part of first of all detecting PCV. Secondly, there are certain anti-VEGF agents which also are probably more better. They respond to a polypoidal lesion as compared to a AMD lesion. Not in 100% of cases. Most of the times it can tell you. And if there is an extrafoveal polyp, I think that is a very important thing. Yeah, of course. So that's what I'm saying. You can avoid a ICG, but if you have it, then it's always better you should do it.
There was a time, I think, we for a very short period we were not doing, but I think if you routinely start doing ICGA, even in today's scenario, you will find at least 20 to 30% of the lesions are outside the FAZ. So even if they're in the macula, you can directly laser them. So I think even in today's scenario, it's very important that you do ICGs in all these patients. Once you start monotherapy, it's never-ending game. You know, it looks very nice, but it's a never-ending game, and patient virtually are always on anti-VEGF therapy. But once you laser the polyps, the BVN part is very easy to tackle. So it's important to find the polyps even now. I think 30% of the lesions, those 30 patients do not require repeated anti-VEGFs if you knock away the polyps.
So I agree with Vinod. Just again, fully agree. That is what I'm telling you. But sometimes, in private practice, the cost is there because you have to charge for ICG every time. That is the only thing. So I agree. So that is what I highlighted from both points. ICG is very essential, as Vinod highlighted, but sometimes you can just get away. Maybe if he's not responding, do ICG. But if you have the facility, patient is ready, it is always I think it is very important to do it, as highlighted by. I just wanted to ask, since you are working in Institute 3, any other points with your higher end machines you see on a polyp which probably we are missing, or any other information we can get with the Octo on PCV?
You see a ICG of PCV, just the ICG. I think 99% of the people would be able to tell that this is a PCV. Okay, but you just show a Octa, just the Octa, to anyone, and only 5% people will be able to tell that this is a PCV.
Even
I'm talking about single imaging modality. So, but once you combine Octa with OCT and fundal knowledge, so everything put together, yes, you can get a fair bit of idea whether you are dealing with PCV or not. But that's why the ICG remains the gold standard. And one thing I learned over many years is that the percentage of eyes you are going to pick polyps, if you do ICGA at the onset, at the first visit, is much higher. If you treat them and then do ICGs, then the percentage of eyes where you can pick up polyps is much less, because the picture gets altered. So it's always easier to do ICG and pick polyps in the first sitting rather than later on.
And on Octa, most of the polyps, in all the studies and everybody are picked retrospectively. There is no study which is saying that we have picked up the polyps and.
I'm so sorry, I have to interrupt.
Yes.
We should go next topic, please. We have just lack of time. We can discuss this after this. Now I would like to invite Professor Pradeep Kumar, who is currently working in prestigious Research and Referral Army Hospital. He's a coveted retina surgeon and has a large base of research. His recent research on injection brolucizumab has been something which has been done in India, and his experience in that field is quite vast. So over to you, Dr. Pradeep Kumar, sir.
So in the interest of time, I'll be a little faster, and to straight away come to the point that where exactly OCT angiography helps. So this is a case where if you see the OCT on the top left hand corner, it does not tell you much about the changes that are happening at the fovea. You may feel that patient is having 6/9, 6/12 vision. Why so? You may not be able to answer. But the moment you look at the OCT angiography, the capillary dropout areas, you are able to predict. And the second thing is, even in cases like myopic CNVM, traditionally we have talked about the role in age-related macular degeneration PCV. Even in case of myopic CNVM, you are sometimes able to pick up the flow signals on OCTA and treat them. Coming to the topic today, macular telangiectasia. So this is something very close to my heart. Before I started my retina fellowship in my post-graduation, I was not even exposed to this diagnosis. But trust me, when you start dealing with retina patients in a clinic, maybe half of the patients who can be avoided intravitreal anti-VEGF treatment are patients of macular telangiectasia. Here lies the importance of this diagnosis. So it's a disease which is bilateral, perifoveal, a neurodegenerative and a vascular disease, occurs because of Mueller cell loss, predominantly in the 5th and 7th decade of life, and has a deep capillary plexus affliction. So there are a lot of differentials which I'll discuss with case example. Normal OCTA has been discussed. Now what we know is the changes in superficial and deep capillary plexus more so temporally, and they are evident with capillary splaying and capillary dropout areas. So these two terms are important to remember. Splaying, that is the vessels will appear to be farther away from each other than they are on a normal OCT angiography, and a capillary dropout area in the temporal zone, in the superficial capillary plexus cut and in the deep capillary plexus cut, you'll see it 360 degree. This I am talking about the early stage. That is how you pick up a mactel on an OCTA. Now these kind of changes have been very well documented, and in this enlarged image, I again emphasize in the left eye, if you see that the changes are more so 360 degrees, while in the right eye, you are only seeing the changes temporally. So that is the time differential between a early and a late non-proliferative stage of the disease. So I'll be running through my slide. I'll straight away come to the example. This is one of our early non-proliferative stage disease, where you see a small inner retinal empty area on the OCT, and then you see the OCT angiography. In the deep capillary plexus, you see a little splaying of the vessels temporally. You make a diagnosis, you simply observe this patient and do not offer any anti-VEGF, steroid or otherwise treatment. 40 to 45% patients of mactel are diabetics and may be falsely labeled as diabetic macular edemas. So coming to the late non-proliferative stage, you may see such kind of OCT. Again, the patient has come to you for the first time, has 6/12 vision, is diabetic, and you see this image. Your first tendency will be to inject. But if you see this OCT angiography image along, sorry, my slides are running. So if you see this image, straight away you make a diagnosis of mactel and you do not treat this patient further. Now coming to the proliferative stage, when you see in the choriocapillaris layer and the outer retina layer, you are not supposed to see any flow signal. Here in the outer retina and the choriocapillaris segmentation, you are seeing a small vascular signal. So this initiates the proliferative stage of mactel, where a CNVM has occurred, and this is the stage where you will like to inject this particular patient. So we have to remember a clear demarcation between the pre-proliferative and the proliferative stage, and not to treat every empty cyst at macula. And everything which appears bulbous on OCT angiography is not a mactel. This is a case of a minor BRVO. I'll come to few of our published cases. This was a case of central serous chorioretinopathy, where we saw macular telangiectasia in addition to the diagnosis of CSC. Now here you see that there are deep capillary plexus changes bilaterally. I hope you are able to appreciate that there is a splaying of the vessels, and the intervessel space is much enlarged compared to a normal FAZ picture that you see. So these are the changes which tell you that this patient has macular telangiectasia in addition to CSC. Now second case is that of PCV with a mactel. So this is an even more confusing picture. So you already had a macular telangiectasia, and now you have a PCV in the same case. Why did we call it PCV? Because the choroid showed classical pachychoroid appearance. We have gone ahead and published about macular telangiectasia being associated with pachychoroid also. So here OCTA comes to your rescue to diagnose the disease. A third case in this series was even more confusing, where we saw acute CSC in one eye and a PCV in the other eye with OCTA. With a single click the slides are running. I'm extremely sorry for that. Now here we come to a case of center involving diabetic macular edema. Now you see this kind of OCT angiography image. Please focus on the deep capillary plexus. Now you are again seeing this kind of vascular splaying, but this is 360 degrees. Please focus on the superficial capillary plexus image. Here you do not see any changes, not even temporal changes. Now this is a case of diabetic macular edema. So here lies the difference, the subtle difference between a case of diabetic macular edema and MACTEL if you were not given any other information and you had to diagnose this case based on OCT angiography alone. So in an advanced stage later on, this case had this appearance. So another case of AOFVD with vis-a-vis MACTEL. Here you see the case may appear to you in the outer retinal section as a proliferative stage of MACTEL, but you do not see any changes in the capillary plexus of SCP or DCP. So here you will not give the diagnosis of MACTEL, but try to address this problem with other multimodality imaging. A fundus autofluorescence in this case will clinch the diagnosis. A simple diagnosis will be a neovascular AMD. In neovascular AMD, you can sometimes see deep capillary plexus changes which are secondary to the CNVM. But the superficial capillary plexus will remain undisturbed. So that is a pointer in differentiating the disease. So it's not only important to diagnose MACTEL, it's extremely important to differentiate it from the more common treatable diseases. We had another case of tractional schisis. Now in this case you see this kind of cyst inside the macula on both sides of the fovea. One may be eager to diagnose as MACTEL as a neurodegenerative disease, but this is a tractional schisis, very much amenable to treatment. If you peel the ERM or ILM in these cases, most of the time the progression halts for 4 to 5 years. And the easiest diagnosis is the CNVM, which has already been discussed. Now coming to wide field OCTA. So wide field OCTA, it has come up recently. We were using OCTA initially only to diagnose foveal diseases, to say the best. But now we have taken it further to diagnose diseases which affect the mid-periphery. With the advent of the DREAM OCT, which has recently been launched, 130 degree of OCT angiography, probably we will be doing much more based on dye-less angiography in treating these diseases. This was a 3 mm scan and this is how a 9 mm scan looks. Till now we had a 9 mm scan, very soon you will have a 15 mm scan in this kind of demonstrations. And when you see a patient of non-ischemic CRVO vis-a-vis ST-BRVO, you are able to offer the diagnosis simply based on a non-invasive, non-mydriatic click in your OPD, and you need not put the patient through any kind of angiography. Similarly, you can see cases of proliferative diabetic retinopathy also, as sir had beautifully shown that if you do segmentation, you are even able to pick up these NVEs most of the time. So this is an evolving method of diagnosis with better software coming in. Very soon we will be able to pick up all these NVEs without having to resort to fluorescein angiography. Now here was a case of retinal vasculitis threatening the macula. So this retinal vasculitis we had been treating, the disease had died down in the periphery. We were all very happy about our success. But when we saw encroachment of these capillary non-perfusion areas toward the fovea, it suddenly struck a chord and we decided that our steroids were not doing enough. We went ahead and started the patient on cyclophosphamide pulse. This patient later turned out to be a case of Behçet's, and we were able to salvage the vision of this patient. So he has lost certain amount of field continues to be on immunosuppression. So this kind of information, when you do not have a firm belief that why do a angiography in this patient, let me just do a OPD procedure, 1 minute click, and you have a diagnosis in front of you, and it gives you a treatment option. Thank you so much.
Anyone from the audience want to ask, or if then I'll go for the question. Okay, so Dr. Pradeep, you have beautifully highlighted the role of the upcoming advances in wide field OCT angiography system. But since Dr. Vinod sir had also mentioned that if we have to look at the microaneurysms in the at the macula, we consider a 3 mm scan rather than having a 6 mm scan because the resolution falls down significantly. So although we'll be able to capture a larger area, that is good, but if we want to see predominant peripheral lesion, that may not always be a neovascularization, but could be even the microaneurysms which could be there. So definitely we are going to miss them. What is your take on that?
Okay, so whenever we are going for a wider field of capture, the narrow field of capture facility still exists in this machine. So you are not perforce having to take a 130-degree scan in each and every patient. It's based on an external mirror that external lens that they are adding to the machine. You remove it, you get a beautiful 9 mm scan on a routine, or a 3 mm scan if you go on higher resolution capture. Still you are able to pick up those microaneurysms. So I agree that the wider the field, the lesser will be the resolution. But yes, both the facilities will be available in these future machines also to go for foveal captures alone.
I think one thing what is different in OCTA is, for example, you are taking a 3 mm into 3 mm scan. So the machine's capacity of the number of B scans per second is 1 lakh per second. So even for 12 into 12 mm OCTA, it is going to take only 1 lakh scans per second only.
Correct.
So the number of scans remain the same and the area becomes much wider. So that's why the resolution markedly falls down. So that is the starking difference between, say, you can say FFA and OCTA. So that is probably what most of the companies are working now, how to increase the scan limit and how to keep up the resolution when we go to the wider field of OCTA.
Absolutely.
Okay, so now we have our chief instructor. Ankur Singh is currently Associate Professor at UCMS, University College of Medical Sciences, and GTB Hospital, New Delhi. And incidentally, me and Bhuvan were faculty at some point of time at that particular institute. So, Ankur, all yours.
Thank you, sir, for this warm welcome and introduction. So with this last topic of the day, I'm going to digress into the field of ICG and FFA. This field has always been dominated by ICG and FFA, and OCT has been a very questionable role. So let's dive into this field of posterior uveitis with the aid of OCTA. So as we know, ICG and FFA versus OCTA, how far we have reached in posterior uveitis. So dual FFA and ICG have been a gold standard in the diagnosis and management of posterior uveitis. Dual FA and ICG gives a global information about the structural alteration as in the central as well as peripheral fundus. As Dr. Vinod sir has already mentioned, it's a dynamic invasive test. It shows leak. It works okay in cases of mild vitritis. There is a global consensus for the nomenclature, and it has been there for 20 years. On the other side, we have OCT angiography, which is a nascent, fast, dye-free, non-invasive technique to visualize and assess choroidal and retinal vasculatures abnormality. So the details, how does it work, has already been discussed beautifully by Dr. Devesh. I will skip that. So now I come to OCTA and white dot syndrome. In acute posterior multifocal placoid pigment epitheliopathy, you see these as creamy white lesions, which on OCT shows focal loss of RP seen as clumping with the loss of photoreceptor layers as seen over here, and look at these fuzzy margins. When you do an FFA in these patients, you tend to see those hyperfluorescent area, and then later on the staining of these placoid lesions as seen on FFA. You do an ICG in this patient, they are hyperfluorescent, and in the late phase you see a subtle hyperfluorescence in these patients, and these same patients shows exactly the same place, the choroidal neuron perfusion area. So what is the benefit of seeing this with OCT angio? Because this should be there in all white syndrome. No. So in multiple evanescent white dot syndrome, we don't see these flow void areas. You see this is a choriocapillary slab of this patient, and you don't see any flow void areas. But look at the ICG of this patient, you see these multiple hyperfluorescent spot which are there in the late phase. So what do you understand by that? Does this disease includes capillaries or not? Yes, it does. So what is the problem in this patient? The problem is that OCT angio was not able to identify the flow circulation in the end capillary vessels. So this drawback of the OCT angio can help us to differentiate multiple evanescent white dot syndrome for other white dot syndrome. So this was an example where the drawback was used to differentiate between the different pathologies. Now again, when a patient comes to us with another white dot syndrome and he has a decrease of vision, you do an OCT angio, you beautifully sees the CNVM as a cause of decreased vision in this patient. And one of this example is punctate inner retinal choroidopathy. And when you see these abnormal vessels in all the layers, and you see this flow which is digressing from the superior to the all the layers in the retina, you're probably looking at a RAP lesion. You see this is a RAP lesion, and this is a patient of tubercular serpiginous choroiditis with an RAP lesions. So OCT can also be used to beautifully evaluate granulomatous uveitis like VKH, where we see these deep lesions which are of variable size with neurosensory detachment. This is the neurosensory detachment seen on the OCT. You do an FFA in this patient, they shows punctate hyperfluorescence. Then later on, these hyperfluorescent area are replaced by hyperfluorescent leakage of the dye, as you can see over here. And you do an ICG in this patient, you see multiple focal granulomas as flow void area, the hyperfluorescent areas. And these hyperfluorescent areas correlate 94% with the flow void areas that we see on OCT angio. And what is the benefit of seeing this flow void area? These flow void areas on treatment tend to disappear, and this tells us that the patient has responded well to the treatment. Now, OCT angio in infectious uveitis. So as we all know, infectious uveitis in like toxoplasma retinochoroiditis, you have a whitish lesion as seen on the fundus over here, involvement of the retina as well as the choroid. And you do an OCT angio in this patient, you see these flow void areas in all superficial, intermediate, as deep capillary plexus as well as in choriocapillaries, telling you that this is just not a retinal pathology, this is also a choroidal pathology. At the same time, you can see these satellite lesions that has been described in toxoplasmic retinochoroiditis. You look at a patient who is a toxoplasmic scar, you see a leak, is it active or not, do an OCT angio and you will see an abnormal bunch of vessel that can help you identify that this is an abnormal vessel that has leaked on FA. So as has already been discussed, how do you see retinal vasculitis? So we always say that OCT angio doesn't shows any leak. So how do we use it? So we know that FFA by its benefit shows leakage, but that's leakage except in Optos. In fact, in the conventional FA can work against it, because in this montage view, if you create a montage view, you don't take the scans at the same moment. So you tend to miss those CNP areas. So you do an OCTA, a wild field OCTA in this patient, and you can beautifully identify those CNP areas. At the same time, decrease in the vessel density in the foveal region, you can correlate the activity. So if there is a decrease in the FD300, then this means the lesion is active, and this has been very much documented in Patcher's disease. Disease entities which was only in the domain of ultra wild field FFA has now been very well depicted with the using of wild field OCTA, such as an IRWAN, which is an idiopathic retinal vasculitis, aneurysm, and neuroretinitis. So one of the most important topic for Indian subcontinent is tubercular choroiditis and serpiginous choroiditis. So how do you see these lesions of serpiginous choroiditis on OCTA? So on OCTA, you see those fuzzy margins of an active lesion as a flow void areas, and with the treatment, these flow void areas tends to develop or they unmask the deeper choroidal vessels. So when you see these deeper choroidal vessels in a serpiginous choroiditis, probably the lesion is healed. At the same time, initially you don't see any flow, but later on the flow will not come because the lesion has healed. Rather, there will be thinning. So always correlate the structural OCT and fast OCT as well as the OCT angio. So always remember that although OCTA is not able to detect the leakage, but it can detect vessel density, which is suggestive of active vasculitis. Decreased flow in DCP, deep capillary plexus, as mentioned by Dr. Vinod, can be promising imaging biomarker to assess disease severity in birdshot retinochoroidopathy. In granulomatous uveitis, OCTA has a 94 to 95% agreement with the granulomas that are seen on ICG. Flow deficit depiction, especially in the deeper retina and choroid, may just be a necrotic inner retina. So, if you see an flow void area, just don't think this is a true flow void area. Look at the structural OCT. It just could be a scar. A scar will not have a flow. So, if you look at the flow, you find that this is a flow void area. Look at the structural OCT. It just might be a scar. So, the interpretation of various pathology on this modality is still evolving. So, what in the end I would just like to say is that OCT is not an alternative for ICG and FFA and uveitis, but a respectable adjuvant. So, as like with any new investigations, OCT requires standardization. Keep limitations of OCTA in mind. Know that it doesn't detect blood flow in vessels which are very small. Inflammation does not detect blood flow. So, keep that in mind while interpreting pathologies in OCTA. Thank you.
Excellent presentation, Ankur, and I'll just like to emphasize one fact that where one finds a very good usage of OCT angiography is in a burnt out choroiditis disease where you have a lot of atrophy. When you try to do a FA or ICGA, you have leak almost everywhere. You're not able to see your flow void areas. But on a OCTA, since you do not have a overlap hyperfluorescence like FA, you are able to appreciate these flow void areas of choroid much better and follow these patients with the treatment. Any comments, Ankur, on this?
I think that's, as I have mentioned before, that an FFA has the benefit that it can show leakage, but this is the benefit which act against it. So, as Dr. Vinod has mentioned, that if you have a wide field of FFA, then it's a beauty. You can just in one click get a CNP areas which are very well seen. But then if you do an conventional FA, you can't take scan of all the site at the same time, and you cannot tell that this place is going to have a CNP area. So do an OCTA in this patient. Even if you are not taking it at the right time, it's just a scan, do it, and you can easily pick those CNP areas. So this will tell you about ways the retina is burnt out, and it will help us you to understand that whether is your treatment doing any benefit to the patient, or you need to step up the treatment. Thank you.
I think it has been an excellent IC, and I can see the next IC speakers already here. So I thank. Yes, please.
Thank you, sir, and thank you, the audience, for joining us. Thank you all. Thank you, speakers. We can have a group photograph, please.
And we thank all the audience, especially the audience who stayed till 9. Thank you on a Sunday morning.